Hello, Facebook Live. How are you doing? I'm Yvette McQueen, MD, emergency physician and travel doc. It is my goal to share my knowledge to help you to live a healthy and productive life and share in your healthcare process. That's Yvette McQueen, MD. You can follow me at all social media, Facebook, Instagram, Twitter, Google+, YouTube, and Snapchat. So it is 3:20 in the morning where I'm at. This is Central Time. And like I said, I'm an emergency physician. And I'm sitting in the emergency room. Or emergency department, whichever one you want to go with. Most people know it as emergency room. That's what it's advertised as, ER. And I don't know if anybody is out there awake, any of my nocturnal colleagues. If you're out there, just tune in and say hey. So tonight, or this morning, whichever coast you're on, I am on Facebook Live to talk about the emergency room and to share some knowledge of what happens when you come to the emergency room, just to the general public. Most people have an emergency that they feel is life-threatening or pain or disability, so they end up coming to the hospital, to the emergency room, for certain things like chest pain or shortness of breath or abdominal pain. They fell, they cut themselves, they hurt their leg, something's swollen and broken, something abnormal, and you know it's not right. So it's something that can't wait until you see a primary care doctor. Or in the United States, we know now that there's several people that don't have primary care doctors, or they can't take off of work to get to their primary care doctor during the middle of the week. So they need to be seen by a doctor, so they come to the emergency room. And so now you have an emergency and you're in the emergency room. What happens now? I just wanted to share some things because there's a misconception that the emergency room can cure all. We know all, we do all. And that is not so. I wish that I had a Star Trek tricorder. If you're a Trekkie or a science fiction person, they used to have this, it looked like a telephone almost, and they can go zzz, see what's going on inside the body and say, I have a diagnosis. No, we can't do that in an emergency room. The emergency room, what we try to sort out is the life-threatening. We need to make sure that you don't have a life-threatening condition that basically that will kill you. So we try to avoid you dying within the next 72 hours. Anything that will cause more harm to you, life or disability, or lose a limb. That is our job. If we can't figure out what is wrong, once again, we don't always have the answers, and we can't do all tests in the emergency room. There are some tests that can be done here, and then there's other that needs to be done as an outpatient or in a doctor's office, and we'll let you know those tests that we can't do. And if we decide to discharge you, we refer you to a specialist or your primary care doctor. So what happens when you come? So you enter the emergency room and you go to a front desk and you sign in. And you need to tell people what is wrong with you. Whoever say, oh, you need to sign in, tell us your problem. Please, 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 please be honest with your problem, because we need to sort you out in different categories. There's different areas of any emergency department. There's a fast track area, which means we can get you in and out as quickly as possible. There's an area for intermediate care or more critical care that needs one-on-one or special equipment or special medicine, and we need to know what the problem is. So please be honest, and we can get you to the appropriate area of the emergency department. Most emergency departments work on the same concept of, if you come and sign in and there's an empty room, we will place you in a room. And then there's a triage process. If we cannot place you directly into a room, because guess what? We're packed, we're full, then at that point you see a nurse that we call the triage nurse. And the triage comes from military time, when they used to sort people by the most critical and life-threatening is seen first. Who can we save first? And that's where triage comes from. And it does not mean that we are discounting your emergency. It's just a system that we need to place people in order. So if you see a triage nurse, what they're going to do is talk to you, what's wrong with you, what your vital signs is, blood pressure, heart rate, temperature, things like that. They may even do a EKG right in the triage room. If there's a room available, once again, in the emergency department, they'll place you in a room. If not, they'll place you in an order of level of, we call it a level of acuity, or how sick you are. And if you're sitting in the waiting room, we know you're there. There's a tracking board. Everything is electronic these days. We know you're there. So once you come into the room, you come into a room like there. See that room? So you come into the room and you sit on the bed or the cart. We need you in a gown. And a lot of people are like, do I need to get in a gown? Yes, because you came here for it to be evaluated. We need to touch you. We need to look at things. You know, if you have a leg problem, we need to look at the legs, the arm, whatever. Yes, you need to get in a gown. And occasionally we need to place you on a monitor. So the monitor is where we actually put patches on your chest, and it records your heart rate. It records how fast you are breathing. It records your oxygenation level, how much oxygen is going into the body and back out. And we like that level to be over 90%. We also need to take the blood pressure. And to know blood pressure is very telling of certain things that are going on. If it's too high or even if it's too low, we know something is going on in the body. And at that point, the nurse will get the rest of your information, like what's your medical problem? What kind of medications do you take? What's your dosage? So, of course, if you've been to the hospital before, your doctor is at that hospital, and most electronic medical systems now keep a record and they may just verify. If that's your first time going to that hospital, we do need to know what your medical problems is, what kind of surgeries you have, if you've had catheterizations, heart catheterizations, your medicine and dosage. What I like to tell some people is to, for the older population, if you want to write down your medications and the dosage, or type it out on a card and keep it in your wallet, your purse, that's great. If you have a smartphone, there is an app for that. And actually most phones too have it right in the medical or the emergency area under your profile. So when you're putting on your smartphone, you put your name, your number, your contact information in case of emergency. You can also list your medical conditions. You can list your medications, you can list your blood type. And so if you're found and we can't, and you're not talking, you're unresponsive, we just hit what we call the emergency button on the cell phone. And we actually, is very helpful to know what someone's taking. Like, it would be very helpful to know if someone's on a blood thinner, certain procedures, certain other medicines we want to give. Things like that. What are you diabetic? Do you have hypertension? Those things are important. So you give the person the information, the nurse, paramedic, it may be, and then you await to be seen by a healthcare provider. Now, some of us have different terms of healthcare providers and how we feel about that. I am a physician, an MD. There's also a physician that can be a DO. You can also be seen by either a nurse practitioner or a physician assistant. If you're seen by a nurse practitioner or physician, that does not mean we think less of your care. That means at that point, it's everybody that's working in the emergency room. First of all, we work as a team. That's the one thing about the emergency room. Everybody is working as a team. And certain conditions or certain acuity, remember I told you about the acuity, that can be seen by physician's assistants or nurse practitioner. That does not mean a physician does not know what's going on. They are working under the supervision of a physician. So they may see you, and if they feel that they can't take care of you, or it's out of their scope, or they need more help, they always in contact with the physicians. We're all working together in the same area, and they'll discuss it, or they say, well, can you just take a look at this person, or do you mind me turning over the patient to you, because I think they're more critical than I can take care of. So you may be seen by a physician assistant or a nurse practitioner. And typically, they, in the emergency room, they will be the ones taking care of things like lacerations or a broken bone. Also, if you are at a larger hospital in a university setting, we call them teaching hospitals, you may be seen by a doctor in training. The doctor in training is called a resident. Some people think of them interns. We don't use that term very often anymore, but we call them resident physicians. Why do we call them resident physicians? Well, that goes back to history, olden days, back in Britain, when the physicians actually used to live in the hospital. So if they were a physician in training, or what they call a physician apprentice, they lived in the hospital 24 hours, and they were a resident of the hospital. That's why we still call training physicians residents. So if you're in a university setting, you may be seen by a resident physician. They're just in training, but there is a supervising physician over it, and they always discuss their cases with them. So you are not there's no experiment to it. They are physicians, and they have been trained, and they have supervision. So you're in the room, and your physician comes in to see you, and they're discussing. You tell them what's going on, what's the problem. They talk to you, they examine you, and then they say, I'm going to do some tests. I'm going to figure out some evaluation. If it's something emergency medicine is like a puzzle. I've decided that these are the pieces that most of the time, 90% of the time, we get the pieces from you. You give us all the pieces. What's wrong? Every now and then we need to add some extra, like blood work, x-rays, CAT scan, different things like that. And we tell you, okay, I'm going to go do this, or I need to start an IV to get things done. That may happen. And so, sorry, my battery low just came on. It kind of distracted me, but I'm coming back. So once we go and enter our orders and things will be done, things are not done in a hurry in an emergency room. I just have to tell you that. I just have to tell you that. And so you standing in the doorway looking at us, it's not going to get the laboratory to get faster, or the x-ray tech to get over here to get the x-ray done faster, or the results. Sometimes it takes the results. It depends on how busy the hospital is, how busy the emergency room is. Things may not be done fast, and we don't plan to keep you there hours. We don't want to keep you away from your family or friends or your duty duties that you have to do or from work. It's just things do take time, and it's a process. So sometimes rushing your doctor or the PA or the nurse practitioner is not helping us at all. So things do take time. We have to gather the information and put the puzzle together. It's not just, okay, now I have the lab, I know what's going on. Sometimes that's great, but sometimes we need all of it together. And once we get the information, we come to you and give you the information. We say, oh, you need this procedure, you need this laceration repaired, or you need this abscess IND'd, or a fracture repaired, or I need to give you this medicine, or I need to give you the fluids to make things better, to turn things around, and repeat the lab and check things is working. I'm going to give you some medicine. Check to see if things working. We always need to check to see things to see if it's working. And then we make a decision. Do we discharge you home? Do we admit you to the hospital? And hopefully it's not the third part that we couldn't save you. But we do have reality. We are not God. There are some people, because God destines that is their time. But I'm talking about the people that we are either admitting to the hospital or discharge them home. And if we choose to admit you to the hospital, it's because that you need further care. We can't take care of an emergency room. You need further medicine, that you're really sick, and we're trying to reverse a process that's going to cause you harm. So we're not trying to punish you by admitting you to the hospital, because we want everyone to be healthy. That's our job as physicians, all our healthcare workers. We're here because we want to help you. We really do. We want to help you. And, it gets frustrating sometimes, but I still love my job. I do. So early in the morning, I see no one joined me, but I hope that this information that I've imparted will give some clarity of what to do when you come to the emergency room, what happens, some of the process. Shoot me some questions if you got them, and I'm here. I'm Yvette McQueen, MD. That's YVETTEMCQUEEN, MD. Ciao for now.